Hello, I am Professor Park Chang-ju. From a doctor's perspective, the most important thing would be to increase the implant procedure success rate. However, what about the perspective of patients? The patients would mostly want less painful and long-lasting anesthesia. In that respect, if a doctor is very good at anesthesia, maybe he can be called a good doctor. That's what the patient wants. So, to take the very first step for that end, let's have a look at the implant local anesthesia today. Let's have a look at the contents of what we are going to learn. First, classification of local anesthesia. Second, anesthetic techniques for maxilla. 3. Anesthetic technique for mandible. 4. The drugs for local anesthesia. Lastly, the summary. The dental local anesthesia can be classified as follows. First, you know this very well, topical anesthesia. Anesthetic is applied on the gingiva. The second one is infiltration anesthesia, or it can be called supraperiosteal anesthesia, because the anesthesia is done over the periosteum. The third one is the block anesthesia. As you can see, it goes into the mainstream of nerve to do the local anesthesia. Sometimes it is called 전달 anesthesia in Korean. Depending on the scope or area of anesthesia, let's classify the anesthesia. Infiltration anesthesia or the supraperiosteal anesthesia would work in the smallest area. The anesthesia can be applied in a wider area with the topical anesthesia. The widest area can work under block anesthesia, which works on the main nerve branch. Depending on the anesthetic depth, let's have the classification. The most shallow anesthesia can be achieved, as you know, with the topical anesthesia. It goes the shallowest in depth. Second, the infiltration anesthesia or supraperiosteal anesthesia, which is injected. The third one is the block anesthesia. It goes to the deepest depth and broadest area. Let's have a look at the topical one first. In dentistry, in general, the most commonly used topical anesthesia is the 20% benzocaine. Hurricane is the brand name. Higher concentration lidocaine, which is 10% lidocaine gargle or spray, can be used for the topical. Topical anesthesia is used usually before injection is done on a patient so that they do not feel the pain. I don't know what your experience is. Mostly under topical anesthesia, 20% benzocaine and 10% lidocaine. Patients, in many cases, feel the needle injection. According to studies, if you really want them not to feel the injection of needle, 60% lidocaine, very high concentration, should be applied on mucosa for 20 minutes. with complete isolation from saliva. Second, in the dermatology department, to remove spots on skin, anesthetic is used. It is called EMLA cream. Compared to local anesthesia, it is very highly concentrated. If you look at here, 2.5% lidocaine and 2.5% prilocaine are mixed together. So this is used for the dermatology, and can we use it in dental offices? According to some research studies, patients feel less pain if this is applied beforehand, but this is the ointment designed for dermatology, and if it is used in dental office, patients complain it's very bitter taste. Even though they wash mouth very thoroughly, the bitter taste still remains, and the choice is yours. Anesthetic techniques for maxilla. Before that, I want to say this first. Maxilla is soft bone with thin cortical bone. That means it has a thin cortical bone, and basically it's soft bone. Therefore, anesthetic drug can be diffused easily and deeply. Compared to mandible, maxilla has very good anesthetic effect. Various nerves on maxilla. The sensory nerve in maxilla comes from the second branch of trigeminal nerve, the maxillary nerve. As you can see, anterior superior alveolar nerve, middle superior alveolar nerve, and posterior superior alveolar nerve are innervating into teeth. On the palate, greater palatine artery and nerve. And in the anterior, nasopalatine nerve and artery, they are running together, as you know very well. The most common technique for maxillary implant surgery is the infiltration anesthesia, which is also called supraperiosteal infiltration. So the area where implants will be placed, buccal, crestal, and palatal size, divided into those three. 1 or 2 cartridges are used. That's the most common anesthesia technique on maxilla. I believe you all do this way. However, on maxilla, block anesthesia can be used. Nasopalatine, middle superior alveolar, nerves can be blocked. When you do implant surgery, the most commonly used block anesthesia is on posterior superior alveolar nerve. As you can see, over the second or the third molar, on the mucobuccal fold, a needle is deeply injected to apply the anesthetic. It is like, compared to infiltration, injecting more amount to deeper area. The main reason for doing this is, especially when you do the sinus lifting, the posterior superior alveolar nerve block can also block sinus membrane. If you don't understand it quite well, when you do sinus lifting, sinus membrane is bound to be touched. As you separate the membrane to put in the bone graft material, in the process, many patients complain extreme pain. Therefore, sinus membrane should be blocked. So the block anesthesia, as you can see, is injected on the mucobuccal fold over the second or the third molar. Posterior superior alveolar nerve block can work for the membrane as well. Please keep that in mind. mandible is clearly different from maxilla anatomically. What is the difference? The mandible, the cortical bone is thicker than maxilla. It is a hard bone. So there are some considerations for local anesthesia. Because of that, the anesthetic drug cannot be diffused easily or deeply compared to maxilla. Because it's hard bone, therefore, the drug cannot be infused deeply. The infiltration anesthesia in mandible can be a little bit more challenging than maxilla, as you can guess. The nerves of mandible, as you know very well, in mandible from trigeminal ganglion, trigeminal nerve comes out, and its third branch is the mandibular nerve, which is the predominantly covering mandible. Inferior alveolar nerve, lingual nerve, long buccal nerve are the representative ones. The inferior alveolar nerve goes through the mandible and, as you can see, innervate all the teeth in mandible. Mandible has very hard bone compared to maxilla. Infiltration or supraperiosteal anesthesia would not work very well, but if we can block inferior alveolar nerve, all the teeth can be under anesthesia. So the sensation of the site where implants will be placed can be completely blocked as well. As implants go into the area with missing teeth, inferior alveolar nerve goes into the lingual mandibular foramen, passes through the mandibular canal, and comes out from the buccal mental foramen. By the way, nerves run together with artery and vein generally, so inferior alveolar nerve runs with inferior alveolar artery and vein. On average, the mandibular canal, which holds all of those, is 3.4 millimeters in diameter, and the nerve, according to studies, it's about 2.2 millimeters in diameter. The inferior alveolar nerve thickness, is it thicker than you thought or thinner than you thought? I think it's much thicker than I thought. This is inferior alveolar nerve block anesthesia coverage. The inferior alveolar nerve from the lingual mandible, where does it go into? Yes, it goes into the mental foramen. Thus, the needle is put there to do the block anesthesia before we go into bone. Inferior alveolar bone nerve is blocked properly. The purple portion, the anesthesia will work, the sensation will die, and all the teeth will be under anesthesia. And you may ask a question, what about the buccal mucosa of molars? It's not under anesthesia. Why is that? The reason is the long buccal nerve is not blocked. The entry point of the injection needle should be put on the mucobuccal fold of the lowermost posterior tooth and inject 1/3 cartridge into the area. The long buccal nerve blocking is not that difficult. 2/3 cartridge should be used to block inferior alveolar nerve and lingual nerve, and the rest, 1/3 of the rest of the cartridge should be used to block long buccal nerve. This is the most common anesthesia technique for mandible. You need to find and inject anesthetics at the location right before the inferior alveolar nerve goes into the mandibular foramen to enter mandible. This is the inferior alveolar nerve block anesthesia. You can use the direct method or the indirect one where you inject in parallel and change the entry direction when you hit periosteum or bone. Regardless if it is direct or indirect, the needle should be put on that location. It is straight above what? It is straight above the lingula. Why? Because lingula is the landmark of the mandibular foramen. So if local anesthesia is injected there, the anesthesia spreads and blocks the inferior alveolar nerve that passes through the mandibular foramen to go to mandible, and the lingual nerve near the area is blocked as well. Then, exactly where is that location? Do we have the data from Korean people? Yes, the data is collated in a research. As you can see here, the mandibular foramen or lingula, because lingula is the landmark of mandibular foramen, because it is where the inferior alveolar nerve goes in. According to a study, the depth at the anterior border of ramus is about 23 millimeters. Once again, the depth at the anterior border of ramus at the mesial side is about 23 millimeters. And the height from the occlusal plane is about 4 millimeters. That is the rough location of lingula, which is the landmark of mandibular foramen in Koreans. This is the injection point to block inferior alveolar nerve. Once again, the depth is 23 and the height is about 4. That's the Korean average. Here, there is a question. Maybe in your office, you use 30 gauge. The thickness is 0.3 millimeters and the length 21. This is mostly used the injection needle. Because the thinner the needle, patients would suffer less. Thin one is okay, but the problem lies with the length. I said that the injection needle should go into how much? 24 millimeters. Therefore, 21 millimeters is not good enough. Therefore, the injection needle may not reach the location that you want it to go. Therefore, even though it is a little bit more painful, thicker needle and longer needle is recommended. Of course, if you make it longer, if it is too thin, it will fracture. Therefore, it should have some thickness. So a longer and thicker product needs to be used to completely block the inferior alveolar nerve or the lingular nerve. The bottom two products cannot go into deep enough for block anesthesia, so you need to prepare something like the first one. Recently, there is no controversy over the local anesthesia, but this can be one when you do the implant surgery. Some doctors do not block inferior alveolar nerve. Why? Because the first reason, if you look at the picture, the needle directly touches the inferior alveolar nerve. That's the fear, and people are afraid that they may touch the inferior alveolar nerve directly. That's the first reason. The second reason, when we do the implant placement in mandible. Why we do not block inferior alveolar nerve? Because we want to make the inferior alveolar nerve active. According to many research studies, during injection, even though the needle directly touches the inferior alveolar nerve, not much damage really is made to the nerve. However, what about this? Before conducting block anesthesia, infiltration or supraperiosteal infiltration was done, and the tip of the needle is damaged. The needle tip bevel is bent. If this type of needle directly touches the inferior alveolar nerve, it will be injured for certain. Therefore, here's my first suggestion to you. For all block anesthesia, including the inferior alveolar nerve block anesthesia, clean needle should be used. You'd better not use a needle deformed or bent as it touched periosteum. Not only me, but other papers also talk about this. If you look at number 1, in the lingual side, infiltration anesthesia is injected. On the buccal side, the infiltration anesthesia is injected. And number 3, infiltration is done a little bit higher. And number 4, a little higher place buccally, the infiltration anesthesia is injected. Why do we do that? To avoid inferior alveolar nerve blocking. Not to do so. Why not? First, we are concerned about the direct injury. Number 2, as I briefly touched upon before, the inferior alveolar nerve, if it is under anesthesia, when we do the drilling or when we place an implant, we may not be aware when we approach the inferior alveolar nerve. That is the big concern. Nerve transmission is similar to electrical impulse transmission. Therefore, if anesthesia blocks the electric transmission, when we do the drilling or place implant, there will be no electric impulse when we approach the nerve. Therefore, more injury may be happening. Look here, visual analog scale. When VAS is 0, what happens? The distance 2, 4, 6. So the patient didn't feel anything regardless of the distance. When the distance was very short, with the infiltration anesthesia only, the patient could feel everything. One more thing, even though distance is very far, the distance between the mandibular canal and the tip of the needle, the patient felt 15 visual analog scale. What is the distance? The distance is quite large. The depth of the anesthesia and what a patient really feels, that there is a difference between the two. When a patient can feel something, even it is far away, and a patient don't feel anything, even it is near the nerve. So that's according to a paper. Recently, it is revealed that inferior alveolar nerve is not just one strand. Here, there's 2 strands. This is the bifid. According to the paper, bifid inferior alveolar nerve. And there are some variations too. It is difficult to detect that on the X-ray, panorama X-ray. Inferior alveolar nerve, bifid inferior alveolar nerve can be guessed by looking at this, but due to the advancement of the cone beam CT, bifid or 3, 4 strands of inferior alveolar nerve can be detected. These things make us scared when we do the drilling or placing an implant. Such bifid inferior alveolar nerve seems to disappear as an innervated tooth go away, fortunately. We place implants in missing tooth area, so the nerve is gone too. So even if such nerves may be seen on panorama X-ray, nerve injury is much lower than we think. So have some courage and have confidence in doing the surgery. Currently, most local anesthesia drugs used in dentistry are amide type. Here, the local anesthesia doesn't have efficacy good enough if it is used alone. Therefore, epinephrine or adrenaline, the vasoconstrictor, is used together. If epinephrine is not mixed, the drug efficacy is very weak. Therefore, lidocaine is used with the vasoconstrictor epinephrine. 1 to 100,000 epinephrine concentration is most widely used, but if you look at the product, 1 to 80,000. Higher concentration epinephrine is also used, primarily used for dermal injection. And 1 to 200,000 epinephrine is also used. This one means epinephrine volume is small, therefore it is used for a patient with a heart disease, so it is to reduce the risk if anything wrong can happen to the heart. So 1 to 200,000 epinephrine is recommended to be used for a patient with a heart disease. Imported lidocaines used quite a lot of people. Those who studied abroad, they were used to using overseas lidocaines, therefore they continue to use the same thing when they come back to Korea. Xylitecin A or Novocol 100 and others are available in Korea too. And the concentration of epinephrine is different. So it's 1 to 80,000. You need to check before you use it. I thought lidocaine is good enough for this lecture, but articaine has emerged these days. I thought it will not compete with the lidocaine, but I think it has positioned itself as some force because it has succeeded in localizing it. This is also amide type. Articaine looks similar to lidocaine. I just want to say metabolism mechanism is different, and articaine is used at higher concentration. Lidocaine is used at 2% concentration, but articaine is used at 4% concentration. That is the problem. The efficacy of articaine is better, but neurotoxicity is increased. Not only the papers or from my personal experience, when I use articaine is used, I experienced many times the tongue paresthesia is the result. This is higher concentration, 4% articaine. Therefore, the safety is lower. Therefore, what I recommend to you is that it's not better to use two drugs. Articaine can be used for infiltration. It is a higher concentration, so the efficacy is better. But for superior alveolar nerve block in the maxilla and inferior alveolar nerve block on the mandible, can use lidocaine, which is widely used. First, classification of local anesthesia, topical, infiltration, and block anesthesia, depending on the area of efficacy. For maxilla, We're soft bone with a thin cortical bone, therefore, mostly infiltration anesthesia is used, and posterior alveolar nerve block can be used as a technique. In the mandible, the anesthesia technique, the cortical bone is thick in mandible, and the bone is hard. So the normal infiltration anesthesia is not good enough. So block anesthesia needs to be done. Some doctors try to avoid it. However, block anesthesia is necessary, as I explained. The drugs used is lidocaine and articaine. I talked about efficacy versus safety and also prices. If you have further questions and if you want to learn some more, I believe that there are some of you who want to learn more. And we have offline courses available with much more content. It's always open to you. Knock knock. Please come to the courses. Of course, you will be able to meet me in person. Then I will come back to you with the new subjects. Thank you for your listening.
함께 해주신 여러분 고맙습니다.